Good morning, everybody. Thank you for coming out today. It's good to see everybody's faces in person. We haven't been together like this in a long time. Welcome to our end of January meeting. Is there any discussion on the December minutes as they are posted? If not, can we have a motion to accept them as they are written?
So moved.
All in favor? All right, let's move on to Mr. Langdorf's going to reorganize the Siac.
And that's where we're at. This is our first meeting in January. So I'm going to open the floor to you to submit a name for a chair and then a vice chair. Do I have any names to submit? Anthony.
I would like to submit Amy Williams to continue on as chair.
Okay. Second. Any other submittals at this point? All right. So all in favor, please manifest it with an aye, yay or nay.
Aye.
Aye. Sorry, yay or nay, one of the two. How about a vice chair? Do we have a name for a vice chair? Anthony.
Lisa Schmidt.
Do I have a second on Lisa Schmidt? Second by Sharon. All in favor, please aye or nay.
Aye.
Any nays? That doesn't count, Lisa.
You've been outvoted.
All right, Amy,
It comes with a tiara, Lisa.
That's right. All right, I'll turn the time back over to Amy.
All right, we'd like to welcome Mike Grove and Laura Manlove to give us a pharmacy analysis review, please.
From the
Good afternoon. Can you all hear me okay? This will help. My name is Laura Manlove. I'm a director with RSM's Public Sector Practice. I've had the pleasure of coming before you all a couple of times before. RSM has conducted a pharmacy benefit manager review at the request of the superintendent, and we are here today with our healthcare expert, Mike Grove, who is participating virtually today. We are adhering to CDC requirements and guidelines, and so thus he must remain virtual. Also with us today is our partner, Jennifer Murtha, who you've also seen. She is our partner providing services to the School Board of Brevard from RSM. So with that, I'm going to stand up here to help drive the slides, but Mike is going to take over and present to you the results of his PBM review. Mike? I can hear you very, very faintly. I don't think you're coming through the speakers, though. Let me see if there's something I can hit. Can you keep talking, Mike? One second, Mike. I turned up the volume. Can you try to test one more time? No. Perfect. I'm going to call you, Mike, and we're going to put it to the microphone. 1 second.
believe they.
Hey, Mike, I'm going to put you on.
On my side. How's it sound?
Yeah. Speak again, Mike.
Is it working?
Yes, you're good.
Okay. Well, you guys are kind of faint, but I'm going to go ahead and go, and I will have Laura stop me if there's any questions that anybody has. But thanks for, I apologize for doing it like this, but we will try to give it the best shot. And just to let you guys know, I'm always happy to answer questions regarding our work offline as necessary. So please know that as well. But like I said, please stop me if you have any questions. I'm going to start on the first slide, just so I'm communicating with Laura. So the work that we did was kind of done, we had three different areas that we kind of performed in regards to this work. And the first of those was the contract review. So basically we took a look at all the various contracts from the last 3 years, your administrative services agreement. You'll see the documents that we looked at on the next slide. But we just basically kicked the tires on the contract, looking at various things like pricing transparency, auditing rights, rebates, etc. So, and based on our review, you can see on slide 4 on the observations, there really wasn't what I would call any smoking guns. In fact, I would say that contract review appeared to be very much standard, what I would say amongst commercial plans for governmental entities. So really the only thing that we kind of have to offer regarding the contract, and I'm going to note that these items would probably take significant negotiation effort with the PBM, but I thought I would go ahead and put them together anyway. But starting, and some of these I will warn you in the next few slides, some of these areas kind of cross in the various categories that we have them bucketed. But you'll see on slide 5, pricing transparency. And I know that this was a big factor with Dawn in regards to trying to move to pricing transparency. I know the industry is just kind of starting to get into this, and like I said, this would take significant negotiation efforts in order to move these forward, as I'm sure Aon would agree. So I won't go through all these individually, but we're basically looking at just putting various pieces of price transparency through the contract in regards to auditing rights and network pharmacy pricing, etc. And then moving on to the next slide, slide 6. This category is auditing rights and rebates, and like I said before, some of these categories are somewhat duplicative. And I guess the first one on here would be disclosing all contracts with drug manufacturers yielding any payment to PBM. Full audit rights. Right now, most PMs, the standard rebate audit typically involves the top 5 manufacturers. As you'll see later, that's exactly what I did in regards to your current rebate audit that we performed. You're limited to the top 5 or select 5 manufacturers. So really it's about trying to get some more of the information behind the contract, and it's not exactly an easy thing to do with the PBMs, and you can blame both sides, but there's obviously certain things in regards to how they make money that they keep to themselves. They have actuaries calculate their profits that are on various contracts. So really what these suggestions are trying to move in a direction where you have more insight into those items. Moving on to slide 7. Specifically, we looked at mail order pharmacy. Again, trying to get more or additional audit rights to that benefit, or actually carving it out and moving that to another vendor where you could potentially have more insight or at a lower cost. Again, this isn't saying anything bad about Cigna. Just these are potential items where the district could potentially save money going forward. Slide 8, specifically around specialty drugs. I know this has been a big concern, and there's potential where you could potentially carve that out separately with another vendor for additional discounts, or just, trying to get additional insight into the various discounts that are provided through specialty drugs. And then slide 9, as far as data access right now, I think Cigna does a pretty good job of providing the necessary information. I don't think any of that information is secretive. I think it's just a matter of potentially moving forward where you could obtain additional access to certain information that maybe you haven't received in the past. And before I move on to slide 10, which takes us to another area that we looked at, are there any questions in regards to our review of the contract?
One point I'd like to just add, Mike, I know that we previously met with the superintendent, Dr. Fed, and with Mark, and reviewed this with you. And we talked about industry standard, and some of these recommendations are common. It's something that you see across industry. I wondered if you could add a little bit of explanation or color to that topic.
Yeah, I think all of our what we provided here as far as suggestions are not common practice these days. These are all relating to, as the industry tries to provide more price transparency. So all of the items that I've discussed in regards to contract review would require significant effort, and I believe they would also require, kind of a change of the industry in regards to how pricing is done and how much insight provided to the client.
Can you address it all? I know it's so new and we're waiting for the actual regulations to come out, but what do you anticipate the impact on from the CCA on transparency and PBMs with carriers and insureds?
I cannot, I'm sorry.
No, can you repeat it? Do you know what I'm asking?
I do. Okay. To know if you wanted to ask. So the question is in regards to upcoming changes with CCNA and the PBMs and the relationship there. Mike, if you could speak a little on that topic. With pricing transparency.
Forward and how things will change in the industry.
Sorry, say that again, Mike.
Yeah, I guess from my perspective, I don't foresee a lot of changes going forward in the near future. Obviously with the new administration at the federal level, You'll see various changes coming through CMS, obviously Medicare and Medicaid pricing. It really kind of drives the industry, not only Medicare and Medicaid, but it also is the basis for most of the pricing that's done throughout for even pharmacy pricing. So I think, it'll probably take a while for the dust to settle. The previous administration had tried to boost pricing transparency, and I think it was kind of heading in that right direction, but I know there was a lot of backlash from the pharmacy industry as well as the medical industry. I think to some extent through this next year, the move to pricing transparency will be somewhat limbo.
Any other questions before we continue on to the analysis?
So Mike indicated these are trends that he is seeing where things are going. He had to prioritize the things he outlined from a return on investment. Where would he, recognizing we're 11,000 members for our drugs, a lot of these indicate that there's a lot of effort that would have to go into them. If he could prioritize those for us, what would be the top three that we should try to go after?
Sure. So just to clarify, this first section here is after Mike's review of the contract and any considerations that the district could build into future negotiations. And as Mike mentioned, some of these are a big lift and may not end up being able to be put into the new contract. It's subject to negotiation, et cetera. But, for our purposes, we wanted to provide them, at least for consideration and for thoughts going forward. We do have another section of the presentation where we go into a pricing analysis. And if we're ready to move into that, we're happy to do that.
Laura, I think Mike was asking, out of all these recommendations that he made, what three would he say are the top priorities we should consider, either with our current contract or if the next time we go out to bid? Is that what you said?
Which ones are feasible, which ones are not?
Right.
I know we're not Walmart. Can't swing that stick. But we're 11,000 members. Pretty.
Mike, of contract.
I think there's probably various top threes, so I'm not trying to get away from answering the question. I think you need to probably look at the ones that are probably the easiest to get to or to just obtain right. And I would say probably auditing right would be the most reasonable in regards to how the industry currently operates. Maybe looking at additional rebate contracts or just anything that would give you more insight into pricing transparency. But again, it's kind of the secret sauce, which has always been that way within the PBM business. So, but I would say auditing rights are probably the easiest way to start. But then also, secondly, would be probably just getting additional data, regular reporting that goes back and forth between the district and Cigna.
You recommend
No, I don't. I didn't go into a lot of depth in regards to the current reports that you get. I don't necessarily think that it's somebody that needs to come in from the outside. It may be something that could be done internally in regards to just bringing the data in and spinning it in such a way that you guys could make sense of it. That may be the easiest way to do it. In that regard, you might want to have the vendor come in and set up some regular reporting that you would been input into a readable format to make sense. But I will be honest, I did not review any regulatory reports that Cigna provides the district.
Are we ready to move to the next section? All right, I'm seeing some nods. They are ready to move to the next section, Mike.
All right, so I'll start on slide 10, and this is a new section that relates to taking a look at the various drug costs that you guys incur, as well as the possibility of the existence of steering certain specialty drugs to Cigna's own pharmacy. So that's kind of what the scope was for us to look at here. So that's what we're talking about on slide 10. Moving to slide 11, and this will be somewhat detailed, so I'll give you time to look at it. But this walkthrough is this slide 12, walk through the approach that we took to looking at various costs, but also the possibility of steering as well. So we started out by obtaining an electronic data file of all state claims for 2019 in the district. So that was a lot of data. We cross-referenced the pharmacy numbers to come up with pharmacy names and locations. We kind of summarized around pharmacy chains to some extent, but there were also certain single location pharmacies. So we set the base by setting up the individual scripts and which pharmacy they were going to by zip code. We also, at the same time we were looking through the file, validated specialty drug indicators and the various tiering to make sure that they aligned with your contract, and we did not notice any exceptions in that. So the framework for the data was very solid. We took a look at it. Moving on to slide 12, Laura. One of the things that we also did with the data, we validated the claim pricing, various types that can exist and exist in your contract, average wholesale price, maximum allowable cost, and customary. And basically, we validated those prices without exception as well. So line 6, we recalculate the ingredient cost based on above price type, and also did not notice any issues at all with the case. And then moving on to slide 13, in regards to our observations, one of the things that we looked at in the contract, there's certain guarantees as far as average discount based on price type, and those are based on average wholesale price. For brand drugs, that's 28%, generic, 84%, and specialty is 55%. So one of the things that we did with the data file is we did recalculation based on the various price types in there and look at those categories, and we did notice that those percentages were met in those categories. And I wanted to let you know too, as far as the disclaimer goes, one of the things we did do was to validate the data within the claims data that we see from Cigna via the district. And so when we say this particular work, it's not a true claims audit in relation to how we work. So it was kind of a top-level audit, just utilizing the data that we provided, not testing against source data. So I just want to bring that to your attention. Any questions on that work?
I think we're ready to move on, Mike.
Team that kind of goes along with the work that we did on the pricing. And the question was, is Cigna steering drugs, specifically specialty drugs, to their own farm? And so you'll see this first paragraph up here. Steering, to some extent, is built into your contractual agreement with Cigna. There's a clause that after one fill of drug at a retail pharmacy specialty drug, this again needs to be moved to Cigna home delivery and or Credo. Credo was acquired by Cigna. It's another specialty pharmacy, and I believe that was midway 2019. So when we look at the data, we can't really call it steering. It's just part of the contractual relationship we have with Cigna that specifies that specialty drugs after one fill at a retail pharmacy need to be moved to Cigna home delivery or Credo. So from a steering standpoint, yes, there's steering, but that's contractually written into your PBM agreement with Cigna. And so from another perspective, looking at the pricing perspective, the relationship with Cigna, are they steering to their own pharmacies in order to obtain additional revenue? We could reach a conclusion on that because in some cases the drug being moved to Cigna was higher in some cases, but in the same amount of cases it was lower. So from a volume and pricing perspective, though, there is no conclusive evidence to say that you're being overpriced on specialty drugs through the contractual relationship. Any questions?
Mike, just a quick. He said something that yes, some prices were higher, some were lower. So what does that mean? Was it an average that the pricing was about average, or are we paying more for the drugs through a Credo, or what? I mean, I think we need a little bit more information on that.
So, Mike, I'm not sure if you could hear Mark's question, but he's getting to the point of let's dive a little bit deeper on the work that you did in looking at the more expensive pricing and the less expensive pricing. How did that shake out in total as an average? Are we breaking even? Are we paying a little bit more on average, a little bit under? If you could go into that a little bit more, that would be great.
Yeah, not a problem. Happy to do that, Mark. I would say it was pretty much break even. It wasn't one way or the other. I think in regards to how pricing is done in general, in order to meet the average wholesale pricing that you are provided and the contractual guarantees would keep that from going one way or the other. It's pretty consistent. Obviously this is something from a contractual standpoint that you could look at to potentially save money as a carve out going with somebody else. But I think from an overall contractual standpoint, I think Cigna makes sure that you guys are kind of made whole in regards to pricing and outside specialty pharmacy pricing.
You outlined that one of the trends carving out. I understand that be a heavy lift with Cigna to negotiate, especially pharmacy outside of it, but best in class, and assuming we could negotiate it, what would be a kind of best case scenario of what potentially the school system could save?
I'll try to repeat.
Okay.
So, Mike, I'm not sure if you can hear the questions that are on the microphone, so I'm going to do my best to repeat. But in summary, I think the question is, and please correct me if I get it wrong, best case scenario, what would be the ideal situation that the district could go into moving forward in regards to pricing for specialty?
In the carve-out recommendation that he said was one of kind of the trends that they're seeing in pharmacy, you know, where would that take us? Because understand, we've got to negotiate with Cigna on that. We've got to carve out that piece. We've got the administrative side of it, you know, but if we're going to save 20% on specialty spend, then it might be worth it. I'm just trying to get an idea of what, you know, the value is there.
So specifically with regards to carving out the negotiations on specialty drugs and the pricing negotiations that might exist, the opportunities there.
Could we save, could,
Yeah.
could we save 20%, 10 or 15 by doing that?
Something as you're going through contract negotiations, Laura, that you're having, you know, working with your broker to model claims and take, you know, your experience from your past claims and modeling to see if there's a way that through another contractual, I guess, purchase through, you know, another specialty pharmacy to see how much could be saved. You would have to go through that type of analysis to reach a conclusion on that.
Is there any possibility? Is there a possibility, Mike, of saving a certain percentage on specialty in particular if we were to carve that out and negotiate separately?
Yeah, I will be honest with you. I think, as I mentioned during the contractual presentation, that it would take some effort, and certainly if you were to go through that process, you would want to understand how much the process going through that would cost compared to the benefit that you would get. But, you know, at the same time, it's putting competition into the process. So but I can't sit there and tell you what the savings would be.
I was going to say, I do think Cigna has in the presentation later commentary with regard to specialty information and potential cost savings. Might keep moving forward and defer the comment.
Okay, Mike, later on in the presentation, there's some discussion from Cigna on specialty pricing. So I think the committee is satisfied for now, and we can continue moving forward.
Okay. All right. So continuing on to slide 15, being our third area that we reviewed, and this was a rebate review for calendar year 2019. Contractually, you're allowed to perform these rebate reviews, and really what it is having a third party such as us validate the amount of rebates invoiced to manufacturers, but then the related payment based on those invoices, making sure that those dollars are passed back to you in accordance with your contract. So that's what we're saying in slide 15. Moving on to slide 16. This kind of relates to the scope, and I think you can probably look at 16 and 17 together. 17 is directly from your PBM contract and relates to what dollars you should be receiving or guaranteed to receive in regards to rebate. And the dollars here by category are kind of fail-safe to make sure that you have at least the minimum that is met in regards to rebate. But based on our review, the minimum were far exceeded, so that did not even come into play. And then we also tested the timing of the rebate payout. Contractually, you're to receive on a quarterly basis, 90 days after the quarter, the rebates that are due to you. for the previous quarter. And then moving on to slide 18, kind of walks through the process that we followed, utilizing the claim data file. We are allowed to select the top 5 manufacturers by rebate dollars received. You didn't necessarily have to receive the top 5. It could have been any 5, but obviously from a coverage perspective, we utilize the top 5 manufacturers. So in all this information, actually looking at the contract that the BBM Cigna has with the manufacturers and going through those calculations by drug type. So we go through this fairly laborious process of trying to match up the various pieces of rebate to the individual claims transaction. So we went through that process and validated those with the contract. And then moving on to slide 19, this is a summary of the top 5 manufacturers, and as you can see, it's blinded for privacy perspective, big contract perspective. You'll see the column, the total rebates invoice. Those are the actual invoice amounts that Cigna sends to the manufacturers, and then you'll see the actual paid amount. So we're validating both of those numbers. The rebates invoice is a much more detailed level, and then obviously total dollars received at a higher level as far as the actual receipt of funds. Now, the difference, and this is consistent with any rebate review, you'll always see a difference here because rebates are invoiced for total Cigna business, not just the district, but for all their other various PPM clients. So what happens here is dollars that you actually receive are higher because of the various rounding, volume rounding that takes place based on multiple clients. So there's no area of concern there because you get a little bit more than what is contractually invoiced. And then from a coverage perspective, we'll move on to slide 20. This represents the total across all manufacturers. 3,037,000 was invoiced, and then you received 3,085,000 in actual rebate. And this gives us about a 57% coverage of the total in regards to what we audited. So gives you fairly good comfort that what you received is fairly accurate. An important contract. And then slide 21 just basically reiterates that you did receive 100% of your guaranteed rebate amount in the time span for calendar year 2019. And I am happy to answer any questions on that as well.
Does anybody have any questions for Mike? If not, thank you for your presentation and for your information. And I do not see Bonnie Doss. Is she not here, Mark? Are you going to cover for her
I'm going to cover.
for our financial update? Yep. Thank you very much, Laura.
Bonnie had a family issue come up this morning, so she asked me to cover for her. I'm going to do my best to do that. She's the financial guru, but I'll do my best on this. I think what's this, you can see here, and actually what we did, because we were asked at one time to put the whole year by month. So if you look in the appendix here, you'll see all 12 months, because we had an ask on that before. So in the appendix, it has all 12 months in the back. But this is just a quarterly summary here. I think the important thing to look at is you look at the first quarter, the second quarter, and the third quarter for contributions. And just as a reminder, between the second and the third quarter, the reason why there is a dip is that is our accrual month. So that's why that shows lower in the third quarter. But you can see where we are and our average on contributions from the board at 3.9. The employees are at 1.5. And on a quarterly basis, we're getting about $16 million in revenue per quarter. That comes out to about 5.467 million on average per month. That's what our revenue stands at throughout 2020. If you look below that, when you look at our total administrative expenses, you'll see on that first line for the first quarter it was $1.1 million. The second month dropped to 6.29. I want to explain that because I think this is important, because this goes back to where our contract is with Cigna. For the first quarter, we chose to, Cigna in our contract gave us the ability to non-charge them for 3 months worth of our premium expenses for them. That amounts to about $237,000 per month. That's what we pay Cigna for the services they perform on our behalf. So the reason why we had a dip in the first quarter is we did 1 month of that. So that's 247 less. You'll see that. The second time, or the second quarter, that's where we did the 2 other months for a total of 474,000 less. So you can see that in the administrative cost there, and you can see how the averaging is out. We're about 1.3 per quarter in administrative expenses for Cigna, and that includes other things that we do as well. Also, we did get this over this year. We got $338,000 in a performance guarantee. In other words, our contract said that if we don't reach a certain percentage on generic drugs, and I think Kelly's back there, she would know this number more than I would, but I think we had to have 91%. Was that what it was, Kelly? Okay. Well, we have a performance guarantee on those drugs. So we didn't quite hit that this past year. So Cigna, through their performance guarantee, paid us $338,000. So you can kind of see that over the period of time with our revenue increasing on that for that particular thing. Let's see, we're at. As far as the clinics, you'll see that in the first quarter, it's 900,000. That's a little bit higher because we had a little bit of December expenses in the first quarter, but otherwise it's remaining pretty flat across the board there. And you'll see where our expenses are. For the year, you can see that our revenue, our expenditures exceeded our revenues by $9.6 million. Now, what the board approved during this last fiscal year was that the board would give $5 million as a lump sum payment, and that's reflected under transfers in. And you can see that during the second quarter and during the fourth quarter, we received that $5 million. The rest of what they will look at as far as a premium, recurring expense will start as of this month in January. So we'll start to see that in our next quarterly assessment. Hopefully we will start to see that pretty soon. But you can see where we ended the year as far as our fund balance at $4.6 million. Another thing that I think is important, because Mike even mentioned some information with regards to rebates, and you'll see that in ABK's presentation. So far this year, we've received $3.9 million in pharmacy rebates, which is also part of our contract with Cigna. With that contract that started last year, we had an increase in the rebates. And what's interesting is, and I didn't have the slide in here, I can shoot you out that information in an email following this meeting, but if you compare the year, so the first quarter of 2020, which is the months of October through December, our rebates were $731,000. For each quarter afterwards, so the second quarter, which is January through March, we received $1.1 million in pharmacy rebates. In the third quarter, April through June, we received $1,040,000. And our last pharmacy rebates were 1.3 or 1.033 million. So we've increased our rebates by quite a bit, which has helped offset with pharmacy increases. So I thought that would be good information to share. I believe that once we get the next quarterly input with rebates, we'll probably be averaging somewhere close to about $1.1 million per quarter. So that's about $4.4 million in pharmacy rebates. And that was due to the contract. So we're seeing some good trends when it comes to there. Obviously, we have some issues when it comes to our large dollar claims, which we'll probably talk about, or ABK will talk about that. And that's where we're seeing the biggest trend. So, any questions on that? All right, thank you.
Right. Good afternoon, everyone. Remind me again how to flip the.
Oh, it's the amount. Just move it. You have to just toggle the.
Okay. So as far as the executive summary, this is what we've been bringing to you quarterly. Although now that we are at the end of 2020, we're able to look at the full 2019 versus the full 2020. So in order to keep the same consistency of pattern, you'll see there's still 3 columns of numbers here. However, the first column of numbers and the second column of numbers are identical because we do have the full complete plan year versus just a certain number of quarters. So when we compare 2019 to 2020, you did have a decrease of enrollment overall of about 1%. And when we take a look at the total gross claims, so before we take into account any of the rebates that Mark was referring to or stop loss reimbursements, your increase in gross claims, medical and pharmacy combined, was 8.2%. And that's looking at it on a per employee per month basis. So it's disregarding the fact that you had a decrease in enrollment. We're just looking at cost on an average basis per enrollee. That increased 8.2%. But your stop loss reimbursements also did increase significantly from 19 to 20. In 2019, there were 247,000, and in 2020, it's 1.7 million. We'll go into more detail on the large claims in a moment, but that's definitely due to the significant increase that you had in your large claims experience in 2020. And as Mark mentioned on the pharmacy rebates, in total for the year in 2019, it was 2.8 million. That has increased to 3.9 million, again, due to those negotiations that occurred during that RFP process for the 2020 contracting. So when we take all of that into account, the total net claims increased year over year by 4.6%, again, on a per employee per month basis. And then when we incorporate the fees into the plan, your total plan costs increase overall 3.7%. So when we look at in the blue box in the middle there, we've got the plan loss ratios. So for 2019, the loss ratio, and as a reminder, that's comparing your total cost versus the premium income to the plan. So in 2019, that was at 108.6%. Ideally, you don't want that number to be exceeding 100 because that means that your costs are exceeding the premium income. In 2020, that increased to 112.8%. So it was a 3.8% change year over year from 19 to 20. And then in the bottom section, we illustrate the per employee per month numbers as well as the annual numbers for the breakout between employee contributions and employer contributions. In total, because of the lack of rate changes from 19 to 20, you'll see essentially it's flat. It does show a negative 0.1%, but that's really just due to migration among tiers. A slight migration among tiers, I should say. I should say, any questions on that page before I move on to the next?
Why did the administrative cost or whatever this is called go up in this year by $2 million or so on line 5, I guess?
Line 4 has the fees. Are you looking at line 4?
Okay.
And it actually went down.
Okay. Yeah, I was looking at the wrong thing. So line 5 is everything.
That is all in combined, yes.
Anthony, I think where the biggest increase was the large dollar claims. So if you look at the stop loss reimbursement, that's where you're seeing it. That's when as I said, that's what's driving a lot of our expenses, are our large claim, our large dollar claim.
Mhm. Yes, and fortunately, you did get that benefit of the pharmacy rebate coming in higher as well to really help offset some of that increase. So that is great news there on that piece. Any other questions on this page?
Actually, maybe it would be helpful, because this is showing a reimbursement of 1.6. Amanda, could you describe can you describe how our stop loss work, so they understand why why I'm saying the costs are more expensive? Does that make sense?
Right. And let me skip a couple of slides here. And because we have a large claim slide here, it might be a good time to talk about that piece. So if you go on to page 36 in your PowerPoint, so you can see here in 2019, you only had 2 claimants that exceeded your stop loss level, which was 425,000. After you have that individual, that's referred to as the individual stop loss level. So each claim itself has to exceed 425,000 to be considered a large claim. Then once that has occurred, you also have what is called an aggregating stop loss deductible, which is listed on here as $387,000. What that means is that once you have significant large claims, even if they exceed the 425,000, let's say you had one claim at 425,000, or 450,000, let's say. Even though that's 25,000 above the stop loss level, you would not receive reimbursements yet on that, because you first have to, in aggregate across all large claims, meet that $387,000 aggregate stop loss level mark. So once you have your large claims have exceeded, the excess is beyond 387,000, then you start to receive reimbursements. So in 2019, you received reimbursement $246,542. What you paid out in stop loss premium in 2019 was $1.2 million. So you certainly paid out much more in stop loss premium than you received in reimbursement. Although, as we know, an insurance like stop loss is designed in this sense. The stop loss company is taking on that risk. So you would anticipate and honestly hope that your stop loss premiums do exceed the reimbursements. And the reason I make that comment is because if your reimbursements, what the stop loss carrier is having to pay back to you, exceed what you're paying them in premium, then it will potentially damage your renewal for the following year, because they have paid you more money than you have paid them. So that's where that comes into play. So then to talk about 2020, this says year to date, but this is the complete calendar year. You did have 8 claims compared to the 2 claims. Side comment here, as a school district, you all are not alone in having a spike in claims in 2020. We have seen a lot of other clients also having a spike in 2020 in large claims. So if that gives you any comfort that there are, you're not alone. This is not unique per se. And a lot of times what we'll see with large claims, you may have that really bad year. It may take a year or 2 to linger off, and then you may go back to 2 claims. That's obviously the hope, is that you go down to somewhere in that 2 range. But large claims are very volatile and very hard to predict. So in 2020, your reimbursements, if we look at those last 2 columns, 1.7 million versus what you paid in premium was 1.3 million. So you did receive back in reimbursements more than was paid in premium. So we did work with the stop loss renewal, back and forth, a lot of negotiations to get that increase down as much as possible. For 2021, the stop loss level is increasing from 425 to 450. And I believe the percentage increase is 23%. Mark, does that sound right to you? I think it's 23% for 2021, which may sound high to you. A couple of points there. Even in a good year, our starting basis point and what we included in the initial projections was a 20% increase, because with stop loss, especially as medical trend continues on, the carrier is taking on more risk. So the trend on stop loss premium increases tends to double or more what regular medical trend is, particularly if you are not increasing the individual stop loss level. So you did increase it from 425 to 450 for 2021, and we were able to negotiate it down significantly, down to 23%. Another point is, while 23% as a percentage, that's a very large percentage. When you think about the total spend of your medical plan, the stop loss is a relatively speaking smaller portion of that. So an increase on stop loss of 23% is significantly less than if we were talking about your medical claims, for example.
Did we maintain no lasers on that?
Correct.
Yeah,
There are no
agreed.
lasers. But yeah, that's another great point. That's something else that is always a potential with stop loss renewals. The carrier always has a right to, in their quote, to laser out, meaning they're in, if they see individual claimants that they anticipate are going to continue on and be very high, they have the ability to say, we will cover everyone except for these individuals. Now, of course, you don't have to accept that quote, but it is an option that all carriers have.
Mike, we only had one carrier that was willing to give us a quote, which we chose, without lasers. Pardon me? No.
Sun Life?
They came in high. It was Cigna that came in without lasers. So we selected Cigna. They gave the best pricing without lasers. Our aggregate stop loss stays the same at 387 for this year, which is good. But obviously, our individual stop loss level has gone up from
How many
425 to 450.
how many school systems?
I would say for my client mix personally is probably about a 50-50 split. It depends on the size. The larger the group, we see less of that. Oftentimes, and it's true with you all as well, keeping that aggregate really helps keep that renewal down, because it's additional liability that the risk is falling to the district, obviously, and not the stop loss carrier. So it does help keep that renewal down. But I would say for my client,
Year, so our aggregate set at
it's, well, this, for the stop loss, this is different. So it's an actual,
I'm talking the aggregate. Where's our aggregate?
for the overall plan. Do you know, Jonathan, if it's 100? If we don't, do they have?
We don't.
Right. No. So there is no aggregate on
Okay,
the
you have an
overall
aggregate stop
plan.
loss on the individual.
We're only
We're
talking,
not carrying ag.
right. We are only
That's what I'm
talking about the aggregate on the stop loss,
Got it.
not the
On the
overall plan.
individual IS.
Yes.
Got it.
Yes. Yes.
For-
Yeah. So to answer that question, there are very few that
School
carry
systems
into
that carry ag.
that carry aggregate on the overall plan.
I just want to say one more thing, because I know there's people who don't deal with the insurance side here. The key for me is you look at the 8 claims this year compared to the 2 last year. And remember, our individual stop loss level was 425. That doesn't include all of those claims that paid up to $424,000 that are driving some of that cost. So those are borne within our medical costs. So those are the behind the scenes that are not appearing here. So that's something I think we need to look at, is what's happening with our high dollar claims. And those claims are 50,000 and above. So something we need to look at.
Any other questions on the large claims? Okay, so we'll go back up to, so this is slide, my numbers are covered up here. I think this is slide 33. Okay, so this just breaks down 2019 on the monthly basis versus 2020 on a monthly basis. So I won't walk through all of this, but I will highlight a couple of points, particularly around December of 2020. So if you notice in the fifth column of numbers there, the total gross claims. Your total gross claims in December were 7.7 million, which was the highest number that you had in calendar year 2020. So despite having stop-loss reimbursements coming in of 366,000, the pharmacy rebates that came in December of over $1 million, if I jump over to the final column for the plan loss ratio, the loss ratio for December, even though you had those rebates and stop-loss reimbursements coming in, was still at 129.7%. So it was a very high month regarding your claim. So again, back to what we were saying on the prior page, but when we blend all of that year together, you're at 112.8%. And I should caveat here too that when we lay this out, we are basing it on what the actual paid claims are, for example, the large claimants. So when we include stop-loss reimbursements in here, this is not saying that you have already received these dollars. It is what you will receive. You either have already received or the remainder that you will receive based on the large claims in 2020. Any questions? Okay, the premium and enrollment summary. We've already talked about the overall. For the year, there was a 1% decrease in the total enrollment, and with no changes to the employee employer contributions, we really end up at the bottom right-hand corner, just a very small change of negative 0.1% when it comes to the premium revenues for the year in enrollment. Okay, so this chart really tries to break down, okay, we've talked about claims, we've talked about fees, stop-loss premiums, and all of this. So this breaks down the individual change year over year in these categories. And then after it breaks down the change by each individual category, it then weights that based on, okay, what's the significance of that increase or decrease year over year? What has the most impact, essentially? So for medical claims, for example, if we just look at medical claims, they increased 6.3%. But when we blend that into the overall increase, which was 5.4%, 4.7% of that 5.4% total increase is due to the change in medical claims. And then the next significant piece would be the pharmacy claims, has an impact of 1.1%. And then the smaller pieces, or actually the offsets, when you were talking about the admin side, are very small. The admin, the stop loss, and the clinic, as far as their impact to your total cost year over year. Okay, and we already talked about the large claims. Okay, so IBNR, incurred but not reported. So this is, as a reminder for anyone who's not that familiar with IBNR. So these are claims that have already been incurred but have yet to be paid. There is always a lag on claim payments, particularly on medical, not as much on pharmacy. So this is the estimate of what is remaining to be paid as of these dates that are listed. So we have completed this calculation every quarter. Typically, because claims do get paid a lot faster now than they did 10, 20 years ago, it's a much faster payment process. But when we measured that as of December 2020 for the medical portion, the estimate without any margin is 4.15 million as far as claims already incurred as of December 31st, but yet to still be paid. So you will continue to see that in 2021. And then for pharmacy, it's 245,000. The reason that we even measure this, a couple of reasons. It's something you do need for your auditor. So your auditor does look at this, particularly on your fiscal year basis. So they do look at those numbers and look at the calculations and make sure they agree that, everything is reasonable in that regard. So you are required to have that for your auditor as well as the 11208 filing. Okay, and then finally, the projections. So you saw earlier when Mark was presenting Bonnie's financials, the December 31st actual fund balance was 4.614 million. So if I just want to make a note, if you are comparing to the last meeting, what was projected for that amount, for that measurement was, let me get there, 2.114 million. The reason that it was a big difference is because at that time we were anticipating that the one-time transfer of the 2.5 million to occur in the first half of 2021. It actually occurred in December of 2020 instead. So that 2.5 million is included in the December 31st fund balance now, where it was not included at the time of the last meeting. So that would have been 2.114 without that 2.5 million. And what was projected for December 31st, 2020 was 2.399. So that was a difference of 285,000 lower. So that I just wanted to make sure if you happen to be looking at that, that would explain the difference that you're seeing there. So then when we get to projections for 2021, at this point in time, again, it's early to know all the details of what's going to play out in 2021 with impacts due to COVID and vaccines and on all of those things combined. But at this stage, we are projecting a fund balance as of 12/31/2021. If you look in the bottom section there, 1.649 million. And your required fund balance estimate, according to the state, is 11.57 million. Therefore, the shortfall as of the end of 2021 would be 9.9 million. And just to kind of to help you all as a reference point, what does the 9.9 million really represent? Depending on what happens with your enrollment in 2021, if you recall, the open enrollment numbers were down. If they stayed down and your revenue was maybe around 68 million, that would be about a 15% increase. And that's not even including trend for 2022. That's just a literal comparison of 2021 expected premiums versus that shortfall. If your revenue increased to 70 million or so, it would start to lower maybe 14% increase plus medical trend. Any questions?
So the projected 2021 loss and gain here, the 4.2, that's including is that projection based on the open enrollment numbers that we just went through as far as who signed up for which plan and all of that?
Yes.
Okay.
So this is, it's inclusive of all of that. And as a reminder, it also, it reflects, if you're looking at the first half of the year, that's why it's actually a $4.2 million gain in the first half versus the $7.2 million projected loss in the second half because of that accounting that Mark was referring to for the June, July. But yes, it is reflective of that. And your
actual updated for the new migration.
The actual open enrollment.
Mark, did we get any? I know I had sent you a list, a deeper dive into the actual migration.
I was going to bring that up during my section right after, but I'll bring it up now since you've asked. Yes. Brian McNeil is here, and obviously I've sent him that information asking him if he could provide that. He indicated that they can't provide it until 1 month of claims is put into place. So he said at the end of this month. Brian, when do you anticipate we would be able to provide that deep dive? So the middle of February, obviously, we'll be able to provide the information that you were looking for, Mike.
Hi, everybody. So Mark asked that I come and speak to everyone about one of our new programs that became available for implementation as of 1/1/21. As you know, specialty continues to be a main driver of spend, and this is a new program that aims to lower some of those for clients, employers on those specialty medications. And it's called Save on SP. And so in the world of specialty medications and all medications really, there's a lot of value out there from a manufacturer perspective, where patients can take advantage of copay assistance programs that are available to help lower their costs. And so as of today, you know, many members who are on a specialty medication very likely are actually using some kind of copay assistance to lower their out-of-pocket cost. This program is actually allowing us to broaden that value to not extend only to the member at this time, but to extend into the employer to lower specialty claim cost by administering these programs and taking additional value that's available from manufacturers. At the same time, lowering the member's cost share to zero through those manufacturer assistance programs. The way this program works is that I'm going to go to the next slide just because it kind of is an illustration of kind of where we are today and how this program would help to lower costs. So in the scenario that I'm talking about, this is a particular member who has a medication whose out-of-pocket cost for the member is $25 per month, so $300 a year, and they also have a $500 deductible. So grand total, that member is responsible for $800 of the cost of that medication for the year. The medication is $5,000 a month, or times 12, $60,000 for the year. So that means the member's paying $800 out of their pocket, but the school district is paying $59,200 for the year for that member. Like I said, a lot of times members have a copay assistance that they've either gotten through Accredo or on their own through their provider. And so oftentimes, if you look at the second circle there, the customer may be using their manufacturer assistance to bring their costs down. In this case, the manufacturer has a program where they'll take the member's cost share down to $5 for the month. So now the member's cost share is only $60 for the year. So the manufacturer is paying forward $740. So they're covering the deductible and the copay minus the $5 that the member's responsible for. But as you can see, the district's costs are still $59,200. So one of the specialty programs that is available is called our out-of-pocket adjuster program. And that is a program that would allow us to take that manufacturer assistance and not count it towards the member's deductible or out-of-pocket max. And so in that scenario, the member's cost for the drug is still $5 a month. So they're still paying their $60, but the manufacturer is actually paying $6,240 because they're covering each month that deductible is not being covered by the assistance, and so that deductible continues on. So that actually can lower the cost for the client to about $53,700. So that's one program that we have that's an option. But the main program that I really want to talk to you about is Save On. And so Save On actually looks at the manufacturer assistance. And what the manufacturer assistance program does is puts out there a limit for the year of what they're willing to pay for the member's cost out of pocket. So typically there's an annual maximum. So in this scenario, the manufacturer has said, we will put forth $12,000 a year is our maximum. So that means every month they're willing to put forth $1,000 to help with the member's cost. As it sits today, the member's only taking advantage for this plan, say, 50 to maybe 150, depending on whether it's a preferred or non-preferred brand medication. So there's $50 or $150 a month that the member is gathering from the manufacturer. The way Save On works is we would actually take that medication and we would actually increase the member's cost share to the maximum allowed by the manufacturer for their assistance. So the member's cost share becomes $1,000, all of which is covered by the manufacturer assistance. So the member's cost is zero. But what that does is that lowers the claim cost overall for Brevard Public Schools. So looking at the last circle, you can see that, again, the member's cost share is 0. The manufacturer is now actually putting forth $11,940 for the year, and the school district's cost for that drug for that patient for the year has gone down to $48,600. So over $11,000 in savings for that one patient's drug for the year. So that's how the program works. It's a little bit more complicated of a program than we put forth in the past, but it's rare that we can come forth with a program that has savings not only for the district, but also for the member. So I'm going to flip to the next slide because this is specifically to the analysis that we've done from a savings opportunity with this program in place for Brevard Schools. And so Save-On is not on every single drug. There's a drug list that's maintained. It's about 95 or so medications that are currently on the drug list. The drug list gets updated twice a year along with formulary changes. So approximately 95 drugs. They are all specialty, so this is only on specialty medications. And currently, in looking at the last 12 months, the spend for those medications that are eligible for Save-On for Brevard Schools was about $3.6 million. If we had Save-On in place, the program would save $708,000 for the year, bringing those costs down to about $2.9 million. So there's some significant savings. If we look at $708,000, that's about 10% of your specialty costs. So to the question of, how much can we save? Can we save 20%? This is an opportunity to impact potentially up to 10% of your specialty claim costs through the pharmacy benefit, while maintaining your integration and the experience for the members. I think when we talk about, can we carve out specialty, can we do this, we have to not only take into the consideration the financial impact, but the impact to the member. Cancer patients are a great example. They highly utilize both benefits. Healthcare is very complicated to begin with. It becomes very hard for members who are going through something like that to try to balance knowing that particular drug is part of a carve-out benefit that's a totally different vendor than what they're used to in their pharmacy, whether it's especially knowing this drug might get held up when it's part of the regimen that's approved already through the medical side. So you might have a drug that's being billed through Cigna for medical that's approved, but it's being held up by a drug that's through a different vendor. So we look at the entire regimen as one for a cancer patient. It's approved all at one, looking across benefits. Just some things to consider, but just bring that forth because we're looking at a program that has some serious potential for savings with maintaining that integration member experience for out along with data. So there are some more details in here I just want to point to. So when we look at that $708,000, some of that is member savings. As I mentioned, members' cost share goes down to 0. So there's about 84 members based on the last 12 months that would be impacted by this program that are on a medication that's eligible for Save-On. Those members in aggregate would save about $54,000 over the year based on what those members are currently paying in the previous 12 months. So actual savings to the school district is about $655,000 approximately. There is a fee to the program, if you will. It's really a percentage of savings. So once we maximize what the manufacturer is willing to put forth, 75% of those savings is passed through, and that number is reflective of the net savings. So that's already taking into account the fee that would be retained in terms of the 25% versus 75% savings.
Kelly, how does this affect the customer's experience? Is there any delay in getting things filled? Is there any process change?
Yeah, so ideally we have 60 days ahead of go live so that we can have mailings go out to members, letting them know that this program exists and encouraging them to get enrolled in the program. So they'll contact Save-On. Save-On does all of the enrollment with the member, guiding them through getting the appropriate manufacturer assistance and getting them enrolled. If for some reason that member does not respond to the correspondence, Save-On will also make outreaches ahead of the go live, trying to get members enrolled. If they don't answer and we're not able to connect with the member beforehand, the way this program works is specialty medications will need to be going through a credo because the program is managed through a credo. And so within the credo processing, there is it's not a prior authorization, but I'm going to say that it's a stop that the credo associate can see that this member is eligible for Save On, and they will warm transfer and get them to the Save On team to get them enrolled. It takes about 5 to 15 minutes, conversation-wise, to get them enrolled in the program. These are the types of programs that are available out there publicly. These are not need-based programs, so there's not going to be a need for them to disclose all of their financial information, and there's not a chance that they're not eligible because of something financial. This is the kind of copay assistance that's available out there commercially that they might get a coupon from even their doctor. But this puts all of these members who are eligible, it gets them enrolled in it, and their cost goes down to zero. Right now, there's probably some members who are taking advantage of a copay assistance program, and there's some that are not. So this will, for those members on these medications, get them enrolled. Like I said, the cost actually does increase to the full copay amount. And so the member will want to enroll in the program to get their costs down to zero. So there's not a delay in that, because with the way the specialty medications are set up from a shipping perspective, members have to correspond with the Credo ahead of their shipment to talk about payment, talk about the shipment, ensure that they're ready for their delivery. All of those things have to take place. There's always a connection with the Credo. And so at that time, if they're not enrolled, we get them to the Save On team and we get them enrolled. Of course.
Apologize if you already said this. So for two things. One, when you talk about outreach to get the people enrolled, is this looking at who we already have on the plan that are using these specialty drugs, or is this we're going to ask everybody to enroll? Okay, is this just this outreach to these specific people who are already using specialty pharmacy? And then the second thing is it a reimbursement, or is it, because you said it increases to the full copay, so is it a reimbursement of what they've already paid out, or are they going to get that discount at the cash register?
It's at the cash register
payment point.
So it's at this. So when Credo adjudicates the claim, it's a secondary adjudication that happens once they're enrolled automatically. To first goes through the insurance. It will return that for round numbers. We'll say it returns $1,000 cost share. That secondarily gets processed through Save On, and the member's cost share is zero.
Okay, so when they go to pay for the drug, they're realizing it immediately.
Immediately, correct. And then that's why immediately, again, the cost that is billed for the drug to Brevard Schools is less that dollar number.
So having it processed through Save On doesn't cause any extra delay in the customer actually receiving their medications?
No, like I said, it's part of the process. So when they're going through the normal process of setting up their shipment, and that's only the first time, right? So this is the first time when we first put this in place, and the members perhaps aren't enrolled in their manufacturer assistance yet. That's when we'll connect them with Save On. We'll get them enrolled. Once that's done, that's for the year, and now everything is just automatic. Next time they go to get their refill, it automatically bills through the insurance, and then secondarily through the Save On program with the manufacturer assistant. And so it'll be, like I said, it will be a need to transfer that member initially if they haven't responded to our initial communications to get them enrolled. But that's one time.
What is the process for, so I've never had a specialty drug in the past. Now I'm being prescribed one. I go to my pharmacy to get it filled. Is there, when a Credo gets that claim, that request for prescription, is that the red flag for it to go to Save On for an outreach at that point in time? So that first time I get my drug filled, I'm going to do my copay, but then from once I'm set up on that.
No, so it'll be from the very first fill. So the way this program works, part of the plan requirements is that specialty has to go through a Credo from the first fill so that we capture them, because otherwise they will end up at the retail pharmacy with $1,000 copay. So it has to be managed through a Credo. So the one requirement would be that we would need to have specialty, those drugs that are part of the exclusive specialty arrangement, go straight to a Credo from first fill. That doesn't disrupt anyone. That's for new starts. So we would just automatically route them to a Credo where we currently route them on their second fill. Actually, probably a better experience from a member perspective, so that there's not the disruption on the second fill when they've just gotten their PA approved and they've just gotten all set up, and now you're telling me I have to change to a different pharmacy. So that's part of the plan requirements so that we can manage the program. But from once a Credo has the prescription, they have an onboarding process with members who are new to the drug, are new to them altogether. To get their information, their billing information. They do assessments clinically, education about the drug. So all of that happens. And within that process, when they're talking to the member about how much the medication is going to cost and they process it, they'll be flagged. Their account will be, their profile will be flagged as a part of the Save On program, and they will be warm transferred over to Save On to get enrolled into that manufacturer's.
Is Save On a separate company or is
They
it a
are
separate
vendor.
division?
They are a vendor that
They're a
that we
vendor
work
that
with to do.
Cigna works with.
Right, and they
So,
do all the
I'm a
education.
little confused. If a cancer patient is prescribed a chemotherapy drug, specialty class chemotherapy drug, at a site where they have to go for infusions and that kind of thing, it has to be processed through Accredo in order for the Save On to work. What if it's not?
So this
How
is
does that get identified?
this is specific to the pharmacy benefit.
Mhm.
So this does not impact any medications that process through the medical benefit. So when we're talking about a chemo, something that the provider is
that
administering,
goes through medical,
that goes through the medical. So that would be outside of the
and
program.
it doesn't apply.
Yeah, you can see actually the biggest categories are in the bottom left in terms of the members and the drugs that are that are part of the program where we're seeing the impact. Arthritis, so we're talking about those Humiras and Enbrels, those type of medications. I think it even lists the top drugs as being Humira, Dupixent, and Enbrel for this population based on the most recent 12 months. Those are the highest number of prescriptions. So it's not going to impact that scenario.
I need some clarification here. Is this a voluntary program, or does somebody have to do this?
So it's voluntary in that they don't have to enroll, but their cost share would change. So it's very unusual for a member not to want to take advantage of a $0 cost share versus again, potentially $1,000. So that is one of the things that.
So how does their cost share change?
So once this program is put in place, this benefit program actually has the technical of exactly how it's done behind the scenes, but the program does actually change the cost share for these particular drugs. And so if a member is not enrolled and they will not enroll, their cost share will return the full maximized cost share that we're maximizing to get the full manufacturer's.
I need that in plain English, please.
Hey, Anthony,
And
So basically, the member's cost share actually changes. So where in your non-Save On drugs, especially medication, if it's a preferred brand for a 30-day supply, is going to be $50. This member's cost share will now be $1,000, but it'll be zero because they're going to enroll in this program.
so
we changed the plan design, Anthony, because the reality is manufacturer assistance won't pay. If the member goes in there and shows a $50 copay, they're not going to get a lot for manufacturer
They're
assistance.
going to get $50.
You have to show the manufacturer that their out-of-pocket exposure is this high number. That's where the manufacturer assistance will jump in and pay. So we're basically modifying the plan design for this limited number of drugs to a higher amount so that we can optimize the manufacturer assistance that's out there. That's the objective.
So I understand what you're saying. I understand the benefit. The problem is that this is, as it's laid out now, it doesn't jive with our collective bargaining agreement, and the agreement is in place. So in the collective bargaining agreement, it says specialty drugs will be filled by the PBM specialty home delivery. This will be phased in to allow the employee to retain 2 specialty fills before being required to switch. So it's my understanding that they're not going to have the 2. I mean, somebody would, I don't understand why somebody wouldn't want to do this, but this is what our collective bargaining agreement says. So I don't understand. I can't be in favor of violating the collective bargaining agreement, and I think we could have a problem on our hands if I'm understanding correctly.
Yeah, I think you'd have to go back and look at your collective bargaining agreement, but the upside for the members and again, it is a program that somebody would have to opt in, and there is an action that has to occur, but their cost exposure is going down because of the manufacturer assistance.
So
And
is
the
there a
plan
penalty for
wins.
not opting in?
Yeah,
I mean, are
they-
you stuck with
Yeah, you're gonna have a
$1,000?
much
Yeah.
higher
Yeah,
out-of-pocket
if you don't opt in, because that's the only way you get the manufacturer to play in, is they see that you have a huge
So
out-of-pocket
it's
exposure.
all or nothing. Everybody's in or everybody's
But,
out.
but are you saying the first time they could take it to a regular pharmacy, or the first time it automatically?
It would be from the first fill, which is why we need to route the prescriptions to Accredo from the first fill.
And I hear what you're saying, it's just, I mean, there's 84 individuals that'd be impacted, but the
Yeah.
savings 650,000. So I mean, I think you got to weigh where that comes into how that impacts the larger group.
Yeah, I can't break a contractual agreement that the members ratified. And I'm concerned that that could be a problem.
Is this a benefit that can be enhanced at any time, or do we have to wait until the next round of negotiations with everybody
That's how it
and
should be
renewal?
done.
Is this something that we're looking for 2022, or is this something that could be a potential opportunity for 2021?
So we encourage it to be done at the plan renewal, but we have gotten approval if it was something that would be of interest to the school district to get in place through special approval for as early as April 1st. Again, we need those 60 days to be able to get the member experience to be such that they are aware of the program and can, get enrolled and not have, any delays there or any abrasion there about a program they're not aware of. So because it impacts accumulators, and has that type of impact, and doesn't, we had put forth that it needed to be done on the plan renewal. However, have requested, if of interest, that we get a special approval to implement if warranted by April 1st.
Kelly, let me ask you a question. The number of people who are currently getting a coupon to relieve some of their co-pays, do we have any idea how many are doing that now, or is that even possible to get?
So I have numbers that were from a bit of a dated, we originally did pull that data when we originally rolled out these programs from a sales ability to sell this program. So it was quite dated. It was, I believe it was run in April of 2020. But just for perspective, at that time, there were 94 customers currently utilizing a specialty copay assistance, manufacturer assistance through Accredo at that time.
So basically, they aren't paying a copay now.
Many of them are not paying a copay now.
Okay.
And they're getting credit towards their out-of-pocket right now.
Right.
They are.
So
So-
that's the downside if they do take advantage of it, it's taken them longer to get to their out-of-pocket max.
Well, that's a good thing for them. It's a bad thing for the system. You guys are giving them credit for something they're not actually paying for.
Gotcha.
Yeah, I think, typically plan intent is that when you have a deductible, that the intent is that the member's actually paying that. And a lot of times, if they are utilizing a copay assistance, they're not actually putting forth that money, but it is counting towards their deductible. And so I would say, yes, with Save On and the out-of-pocket adjuster program, it does not allow the manufacturer dollars, so it does take them longer to reach their deductible. But most likely, these members are going to reach that in another way through their medical. So they may not be. They may be reaching that deductible faster than 12 months of specialty prescription. Most likely, they've got other expenses that are going towards that potentially. But
So this program can't be, it has to be for everyone, or it can't just be for individuals who choose it? I mean, because, right, the majority are going to choose it once they're educated about it, if not everyone. But in order for it to work with us, at this point, it would need to be the member decides to choose it.
right, I mean, for this program when this program goes in place, it is a benefit. It changes the benefit for that medication, and so the copay is actually changed So the only thing that can be done in terms of, it not being a full population of the entire, is if we did it per benefit option, but that's not going, we don't have everybody who's a specialty member in a particular benefit option, only these drugs. So that's not something that's realistic, but it is impacting only, only 84 members. And yes, they would, we did get some data. I think, Brian, you had asked me last year in terms of this program has been in place through Express Scripts for some time. It's newly enrolled for Cigna as a 1-1. The percentage of people that have declined to enroll is, I think, less than 0.5%, because it is to their benefit to get a $0.
I have a
And
question.
that's guaranteed for the year for them for that as well. So, for instance, if for some reason the manufacturer discontinued their copay assistance halfway through the year, the member's cost share would still remain to be 0. Now, the school district would not continue to get any benefit from that, but the member's cost share is still 0.
Is there a way, you said we've got, 93 members that are participating in manufacturer assistance, correct?
As of April of 2020.
Is there any way you could crosswalk that into the 84, and if they're already on it, I mean, Anthony, would you guys be open to, if the 84 are already participating in manufacturer assistance, would you be okay potentially having a discussion on it?
I have to think that there is some more.
Well, Anthony, your language is that the specialty drug will be filled through the specialty pharmacy home delivery program. That is not changing, correct? It would still be filled through
Right. The
specialty.
only thing
Okay.
that is changing from a plan design perspective is that there would not be the grace fills at retail, and I think that was perhaps one of the concerns that you brought forth.
Well, and my question then, because I'm looking at your language, so this change will be phased in to allow the employees to retain 2 specialty fills before the required switch. Is that for anyone? Is the intention of that for anyone that starts specialty? They're given a 2, or is that for phasing in the new specialty required through mail order as of January 1st?
I don't remember the history on that. I think it was for any, I don't know.
Because I'm just trying to see how this violates your CBA.
I think the CBA is the issue there would be the copay, the 50 or the 150. And we had talked about the possibility of seeing, and there's risk involved. And I'm not, by saying this is the risk that I think is there, and I'm not sure if it's worth it, but I think it's something that we should think about. If we were to hold the employee harmless, so for example, if we agree to do the program but keep their, and we do this in-house, because I had talked to Cigna about that, I talked to Brian about that, and say, for example, we start this program, and we say to them, yes, it's going to look, when you talk to Save On, your copay could be $1,000, could be $500, whatever the drug is. In all cases like that, we would reimburse you the difference down to what your copay is normally. So in other words, you pay the $50. But we hold them harmless because we could take the money out of savings to cover that, because I'm thinking most people would join this program. But there's a risk involved. I mean, if we have 20 or 30 people do that, we may not get any savings, and it could actually cost us money. But I mean, that's a possibility of where we do a workaround when it comes to the collective bargaining agreement and those deductibles. But that's something that we had kind of thrown around as an opportunity to do if that's what this committee feels that they would want to recommend.
Mm-hmm. Well,
Does that make sense?
Yes, and that certainly seems more promising, something that I could live with if we could establish that more formally. And when is this scheduled to start if we voted on it?
It's not scheduled to start now, but if we wanted to do it as of April 1st, we could.
Mm-hmm. So we're talking 6 months maybe until the next contract is in effect.
Right.
So.
But with a year-end projected fund balance of wherever we were,
Mm-hmm.
I think it's worth starting it in April. I mean, if this is a benefit to our employees, a significant benefit, because even if it's just $50 a month, that's a lot of money across the year for some of these people who are probably experiencing significant medical costs.
How
And
did we
it's
get back to $50
to the
a month?
plan
I
too.
thought we were at 0.
No, I'm saying what they're
no,
paying
if it did
now
today.
for specialty. I mean, their specialty copay right now going down to 0. And then it's significant savings for our plan, which we desperately need right now. I think we need to find a way. Make it happen, Captain. Can you do it?
Well, like I said, I cannot in good faith vote for something that the members agreed to. You know, it's a legal document. So, you know, I mean, if Mark, that is something we could work out that hold harmless and have that in place, I could move in that direction.
I mean, like I say, there is significant risk, though. I mean, but here's something I think it's important. I don't think Kelly described this. It's different. You know, when you see the television commercials where they say, if you can't afford your medication, we have a coupon, right? It works similar to a manufacturer's coupon like that. But most of those coupons you have to qualify for. So in other words, when you apply for those coupons, you have to list your income, all of the, you know, your race, sex, national, all that sort of stuff is part of the application to get those coupons. Kelly, I want to make sure I'm saying this correctly. Is there any of that information that has to go to Save On in order to qualify?
So Save On will assist the member. So the member will have to provide some information, so whatever the manufacturer coupon is today. So usually they may want to know your sex, they may want to know basic information but it's not, what I'm saying is it's not a financial need-based coupon. So you still need to enroll with the manufacturer, and Save On assists the member in getting that done. But
So
I
you're
can't say
not
that there's no information that needs to be provided.
but it's not income qualifying.
Right. So it's not like
So this could be
foundational.
this-
You know how there's
just-
foundational dollars out there, and some of the, and that's really, to put, members through. That's not the type of program. We're not looking at programs that are truly a needs-based. This is, Humira has a manufacturer assistance program that you could print off of the internet and sign up for yourself. This is a program that allows us to maximize the value that those manufacturer coupons that are out there offer.
But it's not the key there is it's not income qualifying.
Right, these are not
Which I
income
think would be
qualifying.
I think some employees wouldn't like to do that because they don't want to put their income down or qualify that way. But this is not an income qualifying program.
Correct.
But, like I say, I was thinking but I'd like to hear everybody's discussion. I know, Sharon, you put your hand up. I don't.
Question is, these specific drugs, these things that these rebates are out there that are for the year, that it won't happen, that something happens with this mid-year and we're no longer getting the benefit of that amount of money coming back, but the employee, of course, would get the benefit for the year that they've got the zero copay. How does that work?
The majority of, I can't say that these programs will never end. The manufacturer has the right to end the program when they want to end their program, but they have a very strong incentive to maintain their programs to keep members on their medication. So these don't often go away, and we reevaluate the drug list.
Well, if it went away, you just change the copay back down to the specialty pharmacy. The plan has the ability to do that.
Well, actually, for the remainder of the year, the member will remain at a zero copay. So
What she's saying, I think, is if the program disappeared and the money dried up
from the
then what?
manufacturer.
From the manufacturer. And again, I'm with you that that's a hypothetical with a
Right.
very low probability. But if that did happen, the plan could decide to change the copay structure of that mid-year because the manufacturer assistance dried up.
So I'm going to take that back and double check, but my understanding is that we will continue for the year for that medication for the member's cost share to remain at zero. Regardless of if the program happened to disappear, which is unlikely.
So let's play another hypothetical.
So what would happen is, basically what that means is, yes, we would stop getting the manufacturer assistance, and the district would incur an additional, say, $50 for however many months remain in the year, right? So the members, because we're going to guarantee that the member who's part of this program remains at zero for the year.
Okay, so your Save On is gonna, or Cigna's gonna guarantee the member's cost share is
Stays at zero.
$5, $0, whatever.
But
It'll
we
be
have to take
zero.
that off,
Zero.
Yeah.
But there is, like I said, so there's a chance that the program, very unlikely, does stop with 3 months remaining in the year. The manufacturer pulls the program. It's
Well, change a formulary. You're looking at the formulary on an annual basis, right?
right.
Or
so
did
it
you
would-
say
it
two
would-
times a year?
It would drop off of the program at the next formulary change.
Right.
So at the beginning of the year, it would no longer be part of the Save On program. But for 3 months, the district would absorb $50 of copay that would have occurred had the program never existed. Does that make
So
sense?
worst case would be $50 for 84
Or
members.
whatever their
at
copay
this
would have
point in time.
been. So
Okay, another question. So if we went with this Save On for specialties that do not fall under this copay assistance program from the drug manufacturer, would there be any change to our members on the negotiated copay?
the copays would remain as
For the
they are
non-
if the drug is not part of the program. So like I said, it's about 95 drugs that are on the program. If the member's drug is outside of it, not part of the Save On program, they're per the 50, 150, whatever, depending on where the tier is. The only thing that changes for the entire population is that the grace fill for specialty at retail goes away because we don't know what the member's going to get. We need to be able to administer the program through a credo. So, and like I said, the disruption there, I just want to make sure everyone just keeps that in perspective. We're talking about new prescriptions or new to a new specialty patient. Anyone who's currently on a specialty medication is already at a credo once their first fill has passed. So as of today, all your special utilizers are going to be at a credo. Again, we're moving them, transferring them to a credo after their first fill if they happen to get their first fill outside of a credo, which is honestly not probably the best experience for the member because they are ultimately going to end up at a credo. If we get them there on the first fill, they not only have the one time they get their prior authorization, they're all set and they're set, but they also get that immediate education and clinical experience from the nurses and pharmacists who are specializing in their condition that they may not get. And I was a retail pharmacist at the retail pharmacy because of just the nature of how retail pharmacy works. So they may not get that same education, same onboarding experience and knowledge about their medication. So just something to keep in mind. I know it sounds like a takeaway that we're not going to allow members to go to retail for their first fill, but in perspective, it's not any disruption to any current utilizers, and it's actually probably in the end a better experience for the member.
So in other words, let me take this. In other words, these 84 customers that are currently there are currently getting mail order through a credo, so they won't see any difference at all, except they wipe out their copay.
Correct. They'll
'Cause it
enroll in
goes
the
to
program and their
zero.
copay will go to zero.
Have you run into issues with the communication piece, with suspicion about where it's coming from? And that would be my worry on Anthony's concern on not everybody understanding and thinking there's got to be a catch, so I'm not going to do this.
So it may benefit the entire, to put out some more of a broad communication that this program is a legitimate program, because I have had questions come because this is a program where if we're going to send you a letter and if you call Save On, to your point, is this valid? Yes, that makes. And if you don't respond to the letter and they call you, you have to remember they have to ask for information, and that's very uncomfortable for members because you're calling me. So it would, lessons learned from some of the first-time enrollment that happened for 1/1 is it would not be a bad idea to let the population know in general that not everybody is going to be impacted by this, but this is a new program. If you are contacted by Save On, this is why, because
That was my question, because we can't do the notification, and it would never be a notification from us to those 84. It has to come from you all.
No, right.
But an 84 out of 11,000, it's just kind of big. But I do understand. The communication is always an issue, and I
Right.
just wanted to make sure of it.
I know.
So I had a couple more questions. So first of all, is this a new program? Why are we just hearing about this at this point in the year and not prior?
It is new. I mean, Cygnus presented it to us just this year on our renewal, so it's a fairly new program. I don't want to say it's been done elsewhere, but I think you're probably the first national carrier I've seen that actually has rolled this into standard practice. So
We were somewhat aware of it towards the end of the year, Anthony, but negotiations had already done. And, you know, when we were looking at these numbers again, we just thought it was worth taking a look at now. And that's why, you know, even though we're not starting it right from the first of the year, if we start in April, there's significant savings and that'll carry on as long as we have Cigna and Accredo.
And
Well, I
then
think
my other question kind of for the committee is, you know, the audit seemed to have some concerns about Accredo. Is this gonna intensify the potential issues? We're not, you know, to the plan, not looking at it from the members' perspective, but to the plan, because we're gonna be driving more folks there potentially, and we don't know if it's saving us money as it is.
Well, if you recall, our contract with Cigna requires us to go through Accredo or Cigna Pharmacy for any specialty drug. So that's the requirement. And that was something that was part of the RFP. So even though RSM has said we ought to look at that, when we did the RFP a couple of years ago, they came in at the lowest price, the best rebates, all of that sort of stuff. So I appreciate RSM's recommendations, and we should certainly look at that next time we put our ASO and PBM out to bid. But the committee decided together it was better to stay with Cigna because of both of those things. So I don't know. I think Accredo's done a really good job, and when you figure the rebates we're getting from this contract, we're in pretty good shape when it comes to there. I don't think they have a problem. At least my conversation, or when we were meeting with Dr. Mullins, that he didn't say that there was anything wrong with Accredo, just that he felt like you might want to look at farming out your specialty drug as a possibility to save some money. That's what I recall.
Can I ask a question, please? On slide number 41, and I apologize if I don't know the answer to this question already. We're looking at 4 circles there, and the third circle is with the out-of-pocket adjustment, where there's less savings. Is that something that we're already getting advantage of? No.
That's
Okay.
another program that when, you know, Save On is the main program.
Right.
And so if you do both, the out-of-pocket adjuster becomes kind of a wraparound to just capture medications that aren't part of the Save On drug list, to have the ability to not count the manufacturer dollars towards members' deductible and out-of-pocket accumulators. It's a program we've been asked to have that ability. We do now have that ability and present it as an option. Again, with Save On in place, the savings are much smaller because majority of the drugs are most likely part of the Save On program. So it kind of just counts, it just kind of works like a wraparound almost to capture those few that might not be part of Save On, but exist, manufacturer funds that exist.
Kelly, one last question. Can we, well, may not be a last question, I'll just ask it. Is it possible to contact these 84 members in advance or send them a letter saying, we're considering a new program, you guys send the letter, this is outline the program and get everyone's thoughts on it before we even, if we think about holding employees harmless, for example, like I had talked about earlier, could you guys reach out to them, explain how the program works, and get their thoughts on that before we pull that trigger and decide to take that risk? Pardon me? All right. I mean, that's just my thought. Is that possible?
I don't know that that's possible. I don't know that.
Easier to crosswalk them to see if they're in that manufacturer.
Yeah,
system.
I can try to do that. Yeah, I from a timeline perspective, not by April, not to get this done by April. And I don't know who we would, I'd have to take that back to see it. I don't think Savon would do that. I don't know who would do that contact. I don't know, Brian, if you have any thoughts on, like, I'm not sure.
Abilities, member to member, or, Cigna to member.
Well, the RN health coach does have the ability to look at somebody's health records, but I don't know what they look at when it comes to pharmacy. I don't know. That's something.
Yes, but Accredo is the pharmacy, so I can't go to within the Accredo workflow and insert a questionnaire, if you will. But Brian, perhaps the health coach, perhaps, because that's an internal Cigna employee who we could provide, PHI to, perhaps. And I don't know what kind of, timeline we'd be, if they don't respond, how. And we'd have to obviously educate the coach on the program. I would be concerned from a timing for April to do something like that, to be honest.
Yeah,
I think that's,
and I think Katie brought up a good point. If you got 84 members and they're paying $50 a month, they're out of pocket on these medications is $50,000. So, I mean, I look at this as there are very few win-wins in the world. This is actually one that, yes, there is an action. Yes, it requires a change. But that member is going to save $600 a year. The plan's going to save $650,000. I mean, I think these are good things that are worth potentially having a discussion, understanding it's outside of the CBA that's in. But this helps not only the member, but it helps the plan a whole lot. And this is, in this game, it is every place you can save money, it is worth going after, especially in scenarios like this where it doesn't really adversely impact the member.
Mark, going back to what Leslie was saying before, are we currently allowing them to have the 2 specialty fills before they're going?
No, they get one fill at a pharmacy anywhere they want to go to. After that, it goes to
Currently.
That's our current. It's one fill.
Yeah, they're violating the contract already. So.
Oh, well.
I think we need you on our team, Sheila.
Right.
Wouldn't have been that December they got to February. It was when they were first put on the medication. So all these people are currently with Accredo, and it's not changing anything from them except that paying $50, we're going to say. And I can tell you, when my husband was listed for heart transplant, and we were out there paying for his specialty pharmacy medication, anything, because he already had what we were paying for his insulin and all those other things. So anything that would reduce what was going out of my pocket, because I was paying his entire copay for his insurance every month also. So those things, anything you can do to save money for that person,
Right.
try it. At least get their input back.
I just, but also it is going to be for the employees being put on these specialty medicines going forward. It's not just the 84. It's all it's all the other. And this is what I'm thinking. Okay, you're in this horrible situation. All of a sudden, you need this specialty medicine. So you want to grab it at the pharmacy once or twice. You have the money for it. No, you can't. Here's all your paperwork to start filling out to apply for assistance to pay for this. So I mean, that's the other side of this.
What I would,
It's been many years since I worked retail pharmacy, and they don't necessarily carry the specialty.
Yeah,
itself,
I was gonna say, that's actually
it's
not
too
the
heavy of a carrying cost.
experience.
So you can't just drive up to your local store and say, "Hey, I want my 30 days of whatever." They don't have it in stock. They have to order it for you anyway.
Okay.
We had
Right.
My life source person was the first.
Right. Yeah, and that's not typically the experience, is that what it typically is, you get there and it's a prior authorization that now the retail pharmacist has to try to coordinate with the provider to get submitted, and it usually takes some time, and they're not going to order the medicine until that prior authorization is approved.
Okay.
And so, in theory, I think that was the intent originally when we rolled out exclusive specialty, to be a softer, what we thought was a softer approach, and allow someone to get one-time fill. Now, I will say, if it's an acute medicine, there are specialty medications that are considered more acute. So something like something for to prevent bleeding, or to prevent clotting, or something that's more acute. Those are not part of our exclusive specialty list, and those, as of today, don't have to go to a Credo. So it's a subset of what's more chronic specialty medications, and so the experience is not just, let me just grab my one Humira today and I'll worry about all that stuff down the line. That's not how it works.
We can discuss this a long time, but we've been here a long time.
Yeah, sorry.
I do want to just get everybody's thoughts. If we can reach out to the RN health coach and have them reach out to our existing members that could be affected by this, find out that majority of them wouldn't have a problem with this. Is this a program there's certain risk caveats to that? So any new member could say no, they don't want to be part of that, and we would, we'd have to hold them harmless in order to be in compliance with the collective bargaining agreement. Is that a program that this group feels like we should consider? Is there anybody who doesn't think that? Remember, Anthony, I'm saying they would be.
It's not the program that I don't think should be considered. It's the fact that we're doing this outside of the CBA, and I am not comfortable with that. So,
But
to
even
me,
if
a
we
change
hold them
like this
harmless?
should have been negotiated. So,
But if they're hold harmless?
well, that I
Put it in
don't
writing.
I don't see that. I don't, I mean, it's one thing for Mark to say that, but that helps certainly, but just generally speaking, I cannot work outside of the contract.
We would need to
negotiations.
have that put in writing and verified that the hold harmless would be something legally binding.
So if we did that and put that in writing, would everybody in this group feel this is appropriate to do?
Yes.
Yes.
Yeah.
Lisa?
So
I don't think you're any.
I guess I'm trying to understand the risk beyond the way status quo is today. So the hold harmless would require that the member only be responsible for their copay as it is, correct?
Correct.
Which is
Correct.
how it is today. So the only risk I see is that you would not benefit from that one person or two people
Yeah,
that.
there's no
from the-
more out-of-pocket exposure because you guys are already paying
Right.
minus the $50 copay.
It's an exposure to the plan, because instead of getting a 700, we might get 650, or something along
Okay,
those
you're right. A
lines.
risk from reduced
we're holding
savings, but
them
not an
harmless.
increased output of.
Is
No,
this
it's not
a
gonna-
is
it's
this
not
a
gonna cost you
one-time
more.
opportunity? Like
Right.
if you miss the boat to sign up the first time it's offered, you are done? Because back to what Dr. Theddy was saying, in the world of scams that we live in, I can see where a lot of employees would think, this is too good to be true. This is not real. This is a scam. You're asking for private information, and no. Is it the kind of thing that if once they have more education, they hear from more people that this is valid, this is a true program, that they could come back maybe the following month, 2 month, 3 months down the road and still enroll? Or is it here's the boat, get on it or you're missing it?
No, they certainly could, but I think it will also be helpful that it's going to be presented within their experience at Accredo, where when they're presented with it by the Accredo representative, letting them know about this program, that is I think they're more likely to understand it's a valid program at that point than when a solicited call unknowing what's going on comes into their home. But when they say no to that, and then they're in the process of getting their prescription filled in Accredo, lets them know that this is the program, that they're going to transfer it to them. It becomes more of a valid program in their mind. I would think that's a bit of an assumption, but But you know, I mean, someone could enroll at any point in the manufacturer system.
Anthony, a quick question. And I'm new to the school board and in this world. Can we renegotiate or do an amendment to the contract?
Yeah, we could do an MOA, memorandum of agreement, like we've done with COVID, so that is a possibility as well. And that would probably be pretty quick and harmless.
All right, we'll proceed with that then. We will work towards that and either do the hold harmless in writing or see if we can't do an MOA. Thank you. Amy?
For your communications for, there's only one, right? You need a microphone. There you go.
So there's one in your printed material and one was distributed after the deck was already created. This is the one that is in your printed material. It was a communication that was emailed to all employees by Marathon. And then the other one that should be in the deck on the screen up there is the healthcare newsletter that was emailed to everybody on the 20th.
Say that when I got that one,
Which
I
one?
was very happy.
This one or this
No,
one?
it's the last one because there were no attachments to open. It was colorful, inviting. It had super great content, which they always do. But I was really happy and thankful for this is what's going to start coming out regularly. That we're moving in the right direction. I feel like good job.
Right. I think I'm on next, right, Amy?
Yes,
Okay.
you're up.
I said 20 minutes. I'm not going to do 20 minutes because I think we're all kind of tired at this point. But I do want to talk about something that's very important. It's something that Dr. Mullins wanted me to address the group about, and that is his desires of how he would like to see the Siac committee work moving forward. I met with him, and he would like to see the Siac actually meet every other month throughout the year. So, for example, January, March, June, etc. So it's every month. So we meet 6 times as a group for the Siac. But then what he would like us to do is in the off months, form one of 2, well, there'll be 2 subcommittees that he would like to see being formed out of the membership here in this group. And just to give you an idea of how, the committees that he would like to develop, and he'd like everybody to sit on one of those committees, is one that would deal with health and wellness education, because we've had discussions about that in the past, that maybe the education is not meeting all the marks. And if we want to improve, we want to have the input from the committee and work on that sort of thing. In addition to that, he would like to have a subcommittee on data analysis. So in other words, that committee would just focus on looking at the things that we kind of talked about today. I mean, I brought up a couple of times, we need to look at our large dollar claims. Maybe that data committee would look in a deep dive at what those are, what's driving those. And then that data committee would work with the education committee and find solutions that we might be able to put in place. So the committees would come together during a Siac meeting, talk about what they discussed in their committee, and then we could look for solutions, and we could get that either through Cigna's recommendations or suggestions, or it could come from our consultants as far as recommendations there. Our consultants would need to work with both of those groups, but the idea is that you have 2 committees that work together to look for health improvement. Does that make sense? Mm-hmm. And I thought that was a very good suggestion. His thoughts are, the goal is to create an education plan that is based on data, and that will drive health improvement. That's really what this is all about. And what he wanted us to do in these committees is look for areas where improvement is needed. I'll just go through these one at a time. Once identified, look for reasonable fixes that can improve the data. And part of that means looking for the 5 KPIs, key performance indicators, and really focus on those 5 areas of what we're seeing. Then assure that there is that the fix that we're recommending is financially reasonable and approved by him or leadership before we move forward with that. And then develop the education plan and a timeline to implement. Once it's implemented, we would monitor and make changes as needed, and then finally measure the outcomes against those 5 KPI. So that's what I took away from the meeting that we had with him. I also communicated with Paul Gibbs, because on subcommittees, remember, or even with this, we have to be public noticed. So in other words, we before this meeting, at least a week in advance, we put an article in the newspaper that we're meeting, or we can post that on our webpage. So it's one or the other, but we posted in the newspaper for this meeting. But even the committee meetings would have to be posted. So what we could do, and what I've done for the month of February, is schedule a time. Unfortunately, I couldn't get this room for that meeting, but we can get training rooms 3 and 4. And so we can do that. All I have to do is get a notice. And what I'd like to do, if we can today, is I'll have my writing pad up here, and if you could tell me which committee you would be interested in sitting on. And think about those things, whether it's data or whether it's education, and what we can do to better improve our outcomes for the year. And you see where they're coming from. Once the committees once we form those committees, we just have to post that information 7 days in advance. And Paul indicated that committees can't meet at the same time. So we can hold it the same day. So if we have, say, February 25th or 27th, that we can meet. One committee could meet at 12:30 to 2:30 or whatever. The next committee would have to meet right after that. And he said by doing that, we meet the requirements of the law when it comes to public notice and public record. Well, I would, after February, yes. Unfortunately, I couldn't get this room because it's already taken for the 4th Wednesday, but we can certainly, I think the Thursday after that, so I have that date available. So once I have that date, I can shoot that out to you, and if that works for you, and depending on what committee it is and what time, we can schedule that. And then after that, we're on key for every 4th Wednesday of the year.
So, Mark, for clarification, so if we have these 2 committees, then at some point, do we meet together to make recommendations to the superintendent? I might have missed that.
And I forgot to say that, yes. What the committees would do would be to look at whatever data is there, or whatever education plan we're currently doing, and what we can do to improve it at the next Siac meeting. So, for example, we meet in February. The committees would discuss the areas that we think are important. Then the committees would report back during the following Siac meeting, and we could start to work together utilizing the communication committee's input as well as the data committee's input to look for ways to make improvements. And then we would follow those things. Look for the KPIs, look for educational plan that'll drive it based on the data, etc. But yes, they would do that. And then before we put it in place, we would make that recommendation to the superintendent. That's why I said the approval has to be made based on the recommendations of the committees or the Siac committee, actually. And then once he gives the approval, we can move forward with that.
So let's say we're coming up with plan design changes for next year. At some point, we all get back together in this room and we all have a vote on those changes.
I would say plan design or any of those would be outside of the subcommittee, because those are the regular SIAC should be focused on what changes have to be made that we would need to put before recommendations to the superintendent, because those are part of the collective bargaining. But it could be part of that too. But for the most part, I would say plan designs, those sort of stuff would be something we do in this committee as SIAC. Subcommittee would work on data and then the educational help. Any questions? All right. What I'm going to do is I'm going to put my pad of paper up here, and I'm going to put it 6 feet apart so that we maintain our social distances, and I'll stand 6 feet from you. But if you could sign up for one of those committees, I would appreciate that. Thank you, guys. Oh, by the way, I forgot to introduce. We have Kathy. Kathy, I butcher your last name. Kathy Pegg. She's from the Steward Medical Group. And if you wanted to reach out to them, they can offer some things that might be a benefit for the Education Committee on things that they can offer. And they brought, what was your name? I'm sorry, sir. Right. Well, we welcome you to the committee. They brought in these bags for you to take as little gifts, but you may want to introduce yourself to them and see what they might be able to offer if you sign up for the Education Committee and what they can do to help there. There's no other questions. I'm going to go sit down and put these out for you to sign. Thanks, guys.
Is there any other business for the good of the group? If not, do we have a motion to adjourn and sign up for our committees?
Motion.
You can, absolutely.
Okay, everybody have a great day. And we'll see you whenever we meet again.
You done got some time later this week?